Hello, I'm hematologist-oncologist Dr. Tony Talebi. We're back with Dr. John Burns, Professor of Hematology at the University of Miami and Section Chief of Hematology-Oncology at the Miami VA. Now we're going to discuss the treatment of myelodysplastic syndrome. Thank you for being here.
Thank you, Tony.
Okay, so let's say a patient has had low counts, either low platelets or red cells or white cells, which has led to a bone marrow biopsy, which has led to the discovery that the patient has MDS. What happens next?
Well, after we've done the bone marrow and we've looked at the bone marrow, we can then formulate the international prognostic score for the patient, or we could classify the patient according to the FAB WHO scoring system, whichever is your preference, in order to determine what category of myelodysplasia the patient has, and with that, what is the prognosis, as well as what might be the treatment options.
I see. So is there ever a time where you actually wait and watch the patient to see how they do over time?
Yes, I think that's very important, especially in the low-grade myelodysplasia. As we've mentioned in the previous video, myelodysplasia often presents in the later years of life, 70s and 80s. And a lot of other things are going on. And the time course, the trajectory, you might say, of the anemia or of the myelodysplasia, whether it involves other cells as well, is important for us to also prognosticate. Because in many patients, the anemia, although refractory, might be semi-stable for a number of years.
So let's talk about the IPSS again. It's so important. Would you please explain to the patients, how do you score someone with IPSS?
Yes, well, the IPSS, International Prognostic Scoring System, looks at three elements. Number one, whether or not 1, 2, or 3 of the cell lines, the red blood cells, white blood cells, and platelets, are involved, and involved generally means low. Number two, we look at the number of blasts in the bone marrow that we have just done, and that also contributes to the score, whether they are increased a little bit or increased a lot, whether they are on the verge of actual leukemia or not. And the third element is the chromosome analysis that's performed. Some chromosome abnormalities actually imply a fairly good prognosis. For example, abnormalities of chromosome 20, whereas other chromosome abnormalities, such as abnormalities of chromosome number 7, imply a very bad prognosis. And there are subsets of MDS involving the long arm of chromosome number 5, which also has an implication for both prognosis and treatment.
I see. So let's talk about what we call low-intensity treatments. When would you consider either white blood cell or red blood cell or platelet growth factors, for that matter, for a patient?
Well, most often the patient does have anemia. And in many of the cases of myelodysplasia, the anemia is relatively mild, but oftentimes comes to a point where it is causing symptoms such as fatigue and definitely interfering with the patient's quality of life. In these patients in particular, a trial of the red cell stimulating factor, erythropoietin, which comes under various brand names, such as Proquit, certainly are worth a trial. And in many of these patients, it will boost the red blood cell count from a level at which the patient is symptomatic to a level at which the patient can carry on with normal lifetime activities. As for the other growth factors, the white cell growth factors, the analog of colony stimulating factor, and the mimetic thrombopoietin that stimulates platelets, these we have less call for. The white cell stimulating factors, perhaps if the patient has a very low white count and is having recurrent infections or has a very serious infection at the current time. The platelet growth factors we have to be cautious with, because as of yet they aren't approved for treatment of patients with myelodysplasia. because any growth factor can both stimulate the good cells and the bad cells, and there's a concern that any of these might enhance a transformation to acute leukemia.
I see. What about transfusions? When does a patient need either a platelet or a red blood cell transfusion?
Well, the patient, we give platelet transfusions when we don't have other options, you might say, when other treatments are not working and the patient is becoming symptomatic of his anemia. Most often, in most adults, that would be when the hemoglobin goes below 8. But some older patients, certainly they might have cardiac factors, coronary artery disease, giving them chest pain. And they might get chest pain or coronary symptoms when their hemoglobin goes below 10. So in that patient, we try to keep the hemoglobin above 10. As for platelets, generally the patient is reasonably hemostatic down to a platelet count of 20,000. We try to keep the platelet count in our myelodysplasia patients above 20,000. If the patient's in the hospital, we can be a little less cautious, and sometimes the level of 10,000 is used. But as an outpatient, if the patient's at 20,000 today and they're platelet dependent, tomorrow they're probably going to be at 15,000, the next day 10,000. So we are a little bit more generous with platelet transfusions in the outpatient setting than we might be in the inpatient setting. But in general, somewhere between 10 and 20,000 is the cutoff for where we would tolerate a platelet count before giving platelet transfusions.
I see. But now there's a new class of agents called the demethylating agents. Would you please explain what that is and when do you use it?
Yes, there is control of our chromosomes by what we call epigenetic mechanisms. These are things that happen to our DNA in addition to the specifics of the DNA code. DNA is methylated, and this can either result in turning on or turning off of various genes. Likewise, the histones are also involved, and they can be acetylated, chemically modified, to turn on or turn off various genes.
I'm sorry, what is a histone for our patients?
The histones are coatings of the, you might say, like blankets around the DNA that either keep certain areas covered or allow them to open up and be activated. So methylation of DNA is an important regulatory mechanism, and there's a specific enzyme, DNA methyltransferase, which puts a methyl group on DNA and regulates expression of certain genes. Now the various compounds, chemotherapy, you might say, agents that we're talking about here, azacitidine and decitabine, these inhibit the enzyme DNA methyltransferase and thus hypomethylate or impair methylation of the DNA and allow certain genes to be activated and transcribed. And oftentimes these genes are silenced in the course of myelodysplastic or even leukemia. So if we can inhibit the methylation of DNA, we can allow activation of genes that are actually quite beneficial to the patient.
So when would you use these demethylating agents?
Almost any case of myelodysplasia, there could be a role for these agents, but most specifically in the intermediate and advanced cases of myelodysplasia where there is a progression towards transformation to leukemia, where there are increased blasts. It has been shown that both of these agents do delay the transformation to acute leukemia by a year more or less, and they do increase the survival accordingly as well.
How are they administered? Intravenously in the office or subcutaneous at home or pills?
Well, both of these agents currently are available both intravenously, and in the case of azacitidine, it can be given subcutaneously as well. I don't believe the cytarabine is yet authorized to be given subcutaneously. In the future, I do believe these agents may become available as an oral formulation, but right now the choice is primarily between intravenous and subcutaneous administration.
Mm-hmm. Do you have a preference for either one, or no?
Actually, it's about a toss-up. I've had excellent results with both of them. I've had more experience with azacitidine and its beneficial effects, so I tend to favor that one personally, but that's just based upon my experience.
I see. Are there any side effects that patients might experience with these agents?
The side effects are quite minimal, in my opinion. They can suppress somewhat the normal cells that might be a little low to start with, but still at the same time delaying the transformation to leukemia. In some patients, they do cause a complete remission to occur, that all the levels increase towards normal. I've seen that many times. Some patients report feeling fatigued during the week that they're getting the agents. The subcutaneous injection, if not properly administered, can be a little bit irritating. But there are surprisingly a few side effects for the most part with these agents.
I see. Patients with MDS generally feel fatigue anyways. How do you deal with that?
Well, perhaps the most important feature in terms of their fatigue is probably the anemia. And so if we can alleviate the anemia, oftentimes that will alleviate the fatigue. But the fatigue can be multifactorial, and again, MDS, its peak incidence is in the 70s and 80s, and there could be a number of other reasons for fatigue.
Now, there's a special subset of MDS called the 5Q syndrome.
Yes.
What is that, and how does Revlimid play into that?
Yes, some patients have abnormalities of the long arm of chromosome number 5. This is called the 5Q minus syndrome. It's more prevalent in women. And it often presents as anemia, refractory anemia, not responsive to erythropoietin at some point.
Mm-hmm.
And generally with a rather favorable prognosis, generally not transforming to acute leukemia. However, quite remarkably, it was discovered that the agent lenalidomide, a descendant, you might say, of thalidomide, causes in most of these patients, 80% or more, a reversion of the anemia, improvement of the anemia, correction of the anemia, and sometimes even a correction of the chromosomal abnormality in the bone marrow. This benefit often extends for several years. We don't exactly understand how it occurs, but it is a quite gratifying response. When we see it, we do use a relatively low dose of lenalidomide, typically 10 milligrams once a day. And some patients who have refractory anemia for reasons other than the 5Q minus syndrome, some of these patients also respond to lenalidomide. Not all of them, and not as gratifyingly as typically the 5Q minus patient does.
So whether you're using growth factors or demethylating agents or Revlimid, how do you follow the patient to see whether it's working or not?
Well, the primary parameters are in the blood counts, whether or not the hemoglobin's increasing, white cells increasing, platelets increasing. In other words, that the abnormal cells are going back to a normal level. And also, with the more advanced cases, that there isn't evidence of progression towards leukemia. Sometimes the counts may still be abnormal. The patient may still be transfusion dependent and even platelet dependent, but still there is no evidence of progression towards leukemia manifest either by blasts in the peripheral blood or if we do a bone marrow, an increase in the blast. But again, some of these patients also, even though they might be on the verge of acute leukemia, or in my experience, even frankly, leukemic, some of these patients with these agents do get complete remissions that do last for a year or more.
I see. Now, some studies show that up to 90% of our patients take alternative herbs. What do you tell your patients regarding the use of herbs?
Well, in general, I want to know what they're taking. And for the most part, they seem to be innocuous. Over the years, I've seen quite a collection of alternative agents being used. But for the most part, like I say, they seem to be innocuous. I generally would be concerned that any compound that might interfere with platelet function in a patient that's thrombocytopenic. For example, garlic impairs platelet function, and in a patient who's thrombocytopenic, that could be very significant. As we know, aspirin interferes with platelet function. There are a number of alternative agents that contain aspirin-like compounds. Even omega-3, fish oil impairs platelet function. In general, that's good. In the same way that for many patients, taking an aspirin a day is good, unless you have low platelets. So I want to be sure that patients who are taking alternative agents, if they are thrombocytopenic, don't have anything that would interfere with platelet function. Now, sometimes some alternative agents are adulterated with things to make the patient feel good. Certainly quinine could be involved, and quinine's notorious for causing problems with platelets. But again, if the patient explains what they're taking, that's I like to know everything they're taking. Some patients may be taking testosterone or testosterone variants. Sometimes this causes actually an increase in the red cell count rather than a decrease, and this can be a bit confusing in terms of various alternative treatments. But in general, I don't object as long as I know what the patient's taking.
Now, what if you have a scenario where you prognosticate the patient based on the IPSS and they have the aggressive, almost a pre-leukemic phase, and the family does not wish you to discuss the diagnosis, the prognosis with the patient? How do you handle that situation?
Well, that can often be a difficult situation, but I generally do indicate that these disorders and do have a propensity to transform or may transform into leukemia in some patients. And most patients receive this news well. When you say some patients, they generally think that's not going to be me, of course. But I generally don't see this. Occasionally this is a problem. Some ethnicities are very protective of their parents or their husbands or whatever from bad news. But we don't emphasize the word leukemia. We do emphasize the ability of the various agents we have to delay the transformation to leukemia, and that's always received as good news. So I think if we emphasize the positive aspects, again, our ability to delay the transformation, that's both implying that there may be a transformation, but also that we can do something about it.
I see, very nice. Now let's talk about high-intensity treatments. Would you please explain what is an allogenic stem cell transplant, and when would you utilize it in a patient with MDS?
Well, an allogenic bone marrow transplant, stem cell transplant, is where bone marrow or peripheral blood stem cells are taken from another individual and given to the patient to replace their bone marrow. In order to replace their bad bone marrow, we first have to eliminate it completely with chemotherapy or combinations of chemotherapy and radiation therapy to wipe out their bad bone marrow. So with this, obviously, there is the exposure to high-intensity chemotherapy and and radiation of a modest intensity. Once we've eliminated the bad cells, we then infuse the good cells that we've derived from the donor to reseed the bone marrow. I often explain it with the analogy of a gardener who has a garden overgrown with weeds, and you want to eliminate all the weeds. What do? You turn over the garden and reseed it. And that's essentially what we do here. We turn over the bone marrow and we reseed it with the stem cells that we've derived from the donor. It generally takes 2 to 3 weeks for those seeds to start popping through the soil and manifesting as normal peripheral blood cells that then recuperate back to a normal count in maybe 3 or 4 weeks. So a bone marrow transplant is a rather daunting procedure. It involves high-intensity chemotherapy, radiation therapy sometimes as well, to eliminate the bad cells, and then reseeding the patient's bone marrow cavity with stem cells derived from a donor.
So who can the donors be to the patient?
Well, there has to be a very precise matching of tissue types, not red blood cell types, not the ABO, but a more complex system of leukocyte antigens. So oftentimes in a family of siblings, there's a 1 in 3 or 1 in 4 chance that any sibling will match one another. So if you have 3 or 4 siblings, there's a fair chance that we might find a donor. Sometimes in large groups of siblings we don't find any, and on the other hand, sometimes there's only one sibling and we do find a match. So that's a statistical and random event. If we can't find a match in the family, then we have to look to the international registries where people from all around the world, close to 1 million people, have given blood samples and have been tissue typed, and we can see if there's someone somewhere else in the world that matches their tissue type, who's willing to donate stem cells. Today the donation of stem cells is fairly easy on the donor. It's somewhat like donating platelets at a blood bank. We give some growth factors to stimulate the stem cells in the donor. The stem cells then circulate in the peripheral blood, and we can harvest these stem cells by putting the donor on a machine somewhat like a dialysis machine, where blood comes out one arm, goes through the machine, goes back in the other arm, and the stem cells are harvested and saved. They're frozen away. They can be used subsequently, or they can be used that day if necessary. It's quite easy on the donor today. Sometimes we do have to do a bone marrow harvest. That's a little more daunting for the donor. That involves taking bone marrow samples from around the pelvic bones, enough that we're able to reseed the patient's bone marrow.
Sometimes our patients' children ask whether they can be donors to their parents. Is that possible, and why not?
Yeah, well, that's becoming more and more of a possibility. I think most people have heard today about cord blood transplants. Each child would be half the type of their parents, half from the mother and half from the father, so they're what we call haplotype compatible. For bone marrow or peripheral blood stem cell donors, this is inadequate. We have to have 10 out of 10 antigens matching, whereas a haplotype has only 5 out of 10. Sometimes we'll do a 9 out of 10, but that brings with it some increase in complications of this transplant. Or some centers may even do an 8 out of 10, but again, the risk goes up and up. The interesting thing about cord blood is that it is not as dependent upon the complete match, and that actually a half match will not give the problems that a half match with cord blood in terms of rejection and graft versus host disease, complications of a bone marrow transplant, a cord blood won't give these problems that a bone marrow or peripheral blood stem cell of a half match would. So today we can do transplants from children to adults. Well, it's from from the fetus, from the placental, the blood that's left over with the placenta, the cord blood. And interestingly today, even we might combine 2 cord blood to get enough stem cells. But it's a completely, it's an area of transplant that's just being explored. It does result in engraftment, and it is a feasibility in some cases.
I see. So let's just go back to just a regular allogeneic transplant. What are some of the side effects that the patient might experience?
Well, first of all, the patient's going to be exposed to high doses of chemotherapy. Fortunately, today we have drugs to combat the nausea and vomiting that would otherwise occur in this setting. But still, the patient does take a beating, and the patient does lose their appetite, and they don't have much of an appetite often for several weeks. So nutrition can be a complication. They have very low blood counts. We can obviously deal with the low red cell count with transfusion and the platelets with transfusions, but their white cell count is low for oftentimes 10 to 14 days, in the realm where they are quite subject to infections. Moreover, this chemotherapy and sometimes radiation therapy is not only suppressive of the bone marrow, but it also suppresses the immune system. So not only are they subject to infections that are prophylaxed or treated by white blood cells, they are also subject to infections that where the other aspects of the immune system are very important. These involve fungi and other organisms that are highly invasive and difficult to deal with. So there are a number of infectious complications of the process that may occur. Today we do have good antifungal agents, but still these are complications that one has to be very concerned about. Additionally, in an allogeneic transplant, the patient is immune suppressed by the treatment that we give him so that he won't reject the transplant. But the transplant might try to reject the patient. And this is called graft versus host disease. This can be a quite serious illness, especially the acute variety, where the patient may have quite a bit of diarrhea or other system involvement that could eventuate in a fatality. Over time, there's also chronic graft versus host disease, where the graft has a more chronic but persistent attack going on various organs in the patient's body. There's an upside to this complication as well, as whether it's myelodysplasia or acute leukemia, the graft versus host disease also has a graft versus leukemia effect. So the graft also can attack any residual leukemia that's left in the patient. And this does contribute to the success of the transplant in general. But we have a number of medications to modulate the graft versus host disease, but still it is and can be a significant problem.
Right, so it's a very serious deal. What about clinical trials? Would you recommend patients with MDS enroll in clinical trials?
Patients with any disorder should consider clinical trials, because generally a clinical trial involves a trial of best current therapy versus something that is thought to be better. Of course, we have to have something that is thought to be better. So just clinical trials for the purpose of clinical trials isn't what I advocate, unless there's some real potentiality that there's going to be genuine progress as a consequence of the clinical trial, not a clinical trial that was just put together, you might say, at the investigator's whim to try A versus B, and with very little prospect of a real home run being obtained.
I see. When would you recommend palliative care or hospice in a patient with MDS?
Well, in my mind, there's a difference between palliative care and hospice, and I think many physicians don't appreciate that. A lot of the treatment of myelodysplasia is palliative care. In general, we don't cure these patients. We palliate them. We make them live longer. We make them live better. And even in hospice, there you've essentially, let me use the word, given up on really the conventional treatments, and you want to just make the patient comfortable. But that also involves palliation, whether it's the symptom of pain or shortness of breath or whatever. One thing about the hematologic disorders, there generally isn't a lot of pain involved terminally. And when one goes to, when things just aren't working out and the end is obviously near, generally these patients are still quite alert, and they need to be palliated in a different way than other cancer patients. Because again, generally pain isn't the issue. With many other cancer patients, with the cancers invaded the bones and other organs, pain and shortness of breath can be a real problem, and you need narcotic intervention. The myelodysplastic and leukemic patients often are pain-free, or if they have pain, very modest doses of pain medication. So consequently, they are alert, they know what's going on, but their body's failing them. So other issues come up in the hospice arena. For the most part, it's just trying to support them until the inevitable happens. I'm not particularly in favor of withdrawing antibiotics or hydration. Some in hospice, this does happen. But for the most part, my strategy is to try to keep the patient going. As long as they're alert and oriented and interactive with their families and watching TV or whatever, and we can keep them that way with blood transfusions, antibiotics. That's our form of terminal care.
I see. Well, thank you so much for everything. Thank you for watching. We hope this has been educational for you.